Barry Erner, who I've known for a number of years, well, maybe over a couple of decades now. Great pain doctor. I think his knowledge and his approach is as great as his therapies. My name is Phil. I'm one of the compounding pharmacists here at Healthy Choice. Corinne? This is what we do. What we are, we've been compounding since 1997. We are 5 years ago, we left our retail establishment and just moved into a compounding facility that was state of the art. We followed our passion in doing that because we felt personalized medicine is where we are today and moving forward. As genetic testing has become a big play in our lives now, it's going to grow as we move forward. And people with allergies and sensitivities, mast cell issues are all in need of a personalized approach to medicine. And that's where we can come in to help these patients. One of the things we're really about is being dedicated to what we do. We try and provide situations like tonight, provide cutting edge information so you can disseminate this and help you get through your lifestyle. We're here to educate and create. I think education is the key to having a healthy lifestyle in what we do. I think the days of just being told what to do, take this pill and not question it, is over, because Dr. Google is out there and everybody has an answer for something. But the ability to create those solutions for people is the key to what we do. Some of the ways that we help are, we started doing women's health back in 1997. Before, they didn't even call it bioidentical hormone back then, they called it natural hormones. We help men, women, and andropause and menopause. Thyroid has become huge for many patients because of the chemical sensitivities in the world today. Progesterone, thyroid balancing is really important. Dr. Erner tonight is going to be talking about pain management, and he'll probably mention some low dose Naltrexone. And then people with sensitive skins and having derm issues is a major issue that we can help with. And it's really about finding the right dosage form. As I was on the phone with Dr. Erner earlier, we worked with a different physician coming up with a solution for a person who had nerve pain, and we made a gabapentin liquid for him. And he's a 9-year-old boy, and he's done great with it. So it's really about giving the physicians the tools in their toolbox so they can come up with the right dosage forms for the right patient on the right medication. Corinne? And this is who we are. This is a picture of our lab and where we do where we create all of our medicine. If you have any questions, please contact us through our email at info@thehealthychoice.net. Check out our website for upcoming seminars. Next month, I think we're going to be talking about nutritional support for COVID, as well as having an integrated physician with us as well. And at this point, I'd like to turn it over to Dr. Erner and let him take over. Thank you.
Yep, Dr. Erner, you can feel free to share your screen.
Okay, let's see. Am I shared?
Yep.
Great. Do I have my first slide up?
You do.
Fantastic. Sorry, but as Phil said, we know each other so long that I have come back from the age when technology wasn't technology. Anyway, thank you for giving me the time to give a little bit of I don't want to make a lecture, but let's have a discussion about chronic pain. And as this slide tells you, this is the present diagnosis that's accepted in the medical field for chronic pain. But it's really not enough to say that, because right now we actually changed the definition. We now have what's chronic pain and something called high impact chronic pain. And the difference is high impact chronic pain will be associated with a major activity restriction, meaning you will have difficulty getting dressed, you will have difficulty maintaining your job, and the statistics show that 83% of people with this high impact chronic pain are unable to work. And at least 1/3 have difficulty with some form of activities of daily living, from even dressing, feeding themselves, going to the bathroom. So this is a major issue. And the scope of it, it's also important. So let's go to the next slide, if I may. Okay, so here's some facts about chronic pain. It's staggering. If you look at it, it's staggering. Just look at the number in the middle, right here, called estimated annual cost of treating it. $635 billion. That's incredible, incredible. And if you look at the amount of people that are suffering, 116 million. So chronic pain is not something that we can take lightly. It's something that really needs to be addressed. So let's get right into what we would call treatment. I like a little bit of humor. I think that it's important, especially in the treatment of chronic pain, which is such a serious and debilitating situation, that we have to have a little bit of levity, a little bit of humor. But let's talk about the treatment of chronic pain in terms of medications. Here we are: opioids, muscle relaxants, antidepressants, anticonvulsant, anti-inflammatory, anesthetics, and what I call new approaches. If you did a study, and of course everybody has access to Google, but if you look on the medical literature, there are presently 149 total medications that are being used for chronic pain. 149. And you know what that tells you? That tells both the layperson and the physician that we don't have a good answer. And that's something that we have to discuss and work on. If you need 149 different medicines, it means we haven't arrived at a really successful approach. And that means you do need personalized medical treatment. What does that mean? It means exactly like Phil said before. Physicians have to be able to tailor a treatment that works for the patient individually, because you can just spin a wheel and just randomly pick too many medicines. Well, guess what? It's not going to necessarily work. And what works for patient A with chronic pain doesn't necessarily work for patient B. There are also non-medication approaches to chronic pain. Acupuncture is clearly something that's used, and it's gained a lot of momentum, especially because insurance companies finally have recognized and will pay for it. Even Medicare, just as of last year, will pay for 12 sessions of acupuncture. For the government to pay for something, they must have some reasonable, if not outstanding, studies to justify it. Acupuncture has been around for thousands of years, a lot of practitioners. The issue is the practitioner licensed? Is it a medical license? Is it a licensed acupuncturist? These are things that can be discussed and researched by the patient. But either way, if you do see a physician or a licensed acupuncturist, they should have their certificate very much prominently visible for the patient to see. And that's important. Then you have manual medical therapies. Those include things like, in my case, osteopathic manipulative therapy. What is that? Osteopathic physicians are given the degree DO. DO is an equivalent degree to MD. The difference is, in the schooling, we learn manual medical techniques as part of our degree, meaning what people will think of as manipulation. So, for example, chiropractors. So if you think about it, manipulation of the spine, of the body parts, well, both of us, both DOs and chiropractors, will do this. And there's overlap. And some people respond better to one or the other. The difference is that the osteopathic physician, the DO, also has the license to practice in terms of medicine and surgery, so can provide medication. So in some ways, not some ways, but in many ways, it's advantageous. You have cognitive behavioral therapies. It is clear, all the studies show that anyone who is suffering from chronic pain has some degree of either emotional or psychological impediments that require support. It's just what happens. You're in chronic pain, it wears you out. And so you need some type of approach. And there are many types of cognitive behavioral therapies available. And these can be through social workers, psychologists, psychiatrists, group therapy, religious, you name it. It's actually, there's not an absolute one that is so far superior. But the bottom line is you must support the emotional and psychological effects of chronic pain. Relaxation techniques. Those are things like yoga, Tai Chi, meditation, anything and everything that is encompassed in relaxation, because there's no doubt there is an incredible amount of stress on patients with chronic pain. Biofeedback is another technique that's been used. TENS, which is transcutaneous electrical nerve stim. That's basically where you have an electrode with electrical stimulation applied to muscles. Quite honestly, the statistics and studies on this are not overly favorable, but there are newer techniques called CES, which is a combination of both a local anesthetic and a deep electrical stim that are showing some promise. Diet. Well, we know that food influences inflammation. We know that things like ginger, turmeric, these are things that have anti-inflammatory effects. There are herbs that are available that can also have anti-inflammatory. And there are diets. There are many, many diets. The Mediterranean diet, for example, has been shown to be helpful in reducing inflammation. People will follow a vegan or vegetarian. Weight loss can be important in somebody, for example, who is obese, and the actual obesity is contributing to joint pain just by the physics of extra weight. So it is very, very important and includes a multitude of issues, not just what you eat, but a question of supplements and herbs and what we call nutraceuticals, which are things that are useful, that are nutritional over the counter, but yet have value that are almost like pharmaceuticals. For an example, something called theanine. Theanine is a derivative of tea, but it has calming effect. And in many patients who take it, it helps sleep, because we know that sleep disorders often accompany chronic pain. And surgery and invasive procedures, trigger point injections, epidurals. I'm not going to cover that because I think that that's best covered by a surgeon, and I am not a surgeon, although I do administer trigger points in my office. Again, those are helpful, but in terms of chronic pain, they don't always give long-lasting results unless it's part of a comprehensive program designed for the patient to address all the components, as I mentioned, psychological, emotional, physical. So, chronic pain. Chronic pain is something that there are textbooks written about. There continues to be more and more data generated. So in this small, brief, let's say, webinar, I try to at least give a little taste of what we as physicians are faced with in our ability to treat and to assuage what's become an incredibly complicated and costly, not only in terms of actual the finance, but in terms of the loss of activity of daily life, the loss of joy, the loss of pleasure. We all know, as we have been experiencing this pandemic, how much stress and how much compromise of our social life has been a part of this. Well, patients in chronic pain, they've had to deal with this well before this pandemic. At this point, I'd like to open it to questions and answers I can hopefully provide.
Wow, thank you. That was very, very informative. We already have a question from somebody, but it's kind of a three-parter, so I'll break it up. Hello, my doctor recommended a new medicine, LDN, since I was diagnosed with transverse myelitis. What are the common side effects?
Okay. All right. So LDN. LDN stands for low-dose naltrexone. Naltrexone is an old medicine. Naltrexone was actually a medicine that in a standard dose, which would be 50 milligrams, was used for people who had opioid overdose. In the 1980s at Penn State, a Dr.Barry and then others discovered that in low doses, and we're talking about a 10th, 5 milligrams, or even less, a 20th, 2.5 milligrams, it stimulated a totally different pathway. It affected the brain and the architecture of the brain, something called the astrocytes, which are brain cells. And what it does is it changes our perception of pain and actually changes the inflammatory response. So when you say transverse myelitis, what you're describing is an inflammatory condition. So LDN has been prescribed for things such as multiple sclerosis, Crohn's disease. In fact, there was an article only last week from the dental journals for the use of LDN as a superior treatment for atypical facial pain. So what I'm trying to say is that low-dose naltrexone is finding itself as an incredibly useful part of our armamentarium in treating chronic pain. And I believe it's absolutely worth trying. The issue is do not take it at night to start because it has occasionally caused sleep disruption. Other than that, like any medicine, anything you take in your body, somebody can experience a little bit of nausea or stomach issues related to anything that they take, whether it's Advil, aspirin, Tylenol, anything can upset the stomach. But truthfully, LDN is among the most non-toxic and almost free of side effect medications that we can use.
Great. All right, 2 other questions about LDN. How long do patients usually see improvements while taking LDN?
Okay, so first, we need to address the proper dosage. And medical adage is you can always add more, but you can't take away. So, for example, let's say I have a patient with, as I said, the atypical facial pain. I would start with the low dose of naltrexone in the lowest form. So whereas the studies seem to show between 2.5 and 4.5, I might start the patient at 1 or 1.5 milligrams. And then I tell them to take it in the morning, and I give at least 2 weeks time frame to see if there's any effect. If the patient says, "Doc, you could be giving me a sugar pill, I don't notice anything," well, then I increase it. And I'm sorry, but it is a bit of trial and error because we don't have a standardized dosage and everybody is different. I'll give that 1.5 milligrams to someone and it'll be right on target. I'll give it to someone else, and like I said, they'll say, "You could be giving me a sugar pill." And you titrate, meaning you adjust the dosage upward, but you always start with a small dose first to see how it's tolerated. And as I said, you try to avoid giving it at night.
Gotcha. And she wants to know, how long does the medicine typically stay in your body?
Okay, what's happening is it doesn't stay in the body that long at all. But what it does is it basically causes changes in brain perception of pain, and it changes the inflammatory pathways. And that's what's profound. And that can be useful for the course of a day. But it does not last, for example, over 3 or 4 days. It's not a long-acting medicine or a time-released medicine. For example, Valium, benzodiazepine, diazepam is its name. You take that, it has a very long half-life. That means the body degrades it very slowly. So 1 dose of Valium, if you measured it in your urine or blood, will still be there up to 36 or 48 hours, which is one of the issues with Valium, and that's why they developed shorter acting. LDN is not long acting, so you do need to take it daily.
Gotcha. Okay. And she says, one of my fears is that she is on an opioid already. She read that LDN is an opioid antagonist.
That is correct. That is one of the things that LDN will not work well with. It is an antagonist, and its effect. Okay, so as I mentioned, LDN, N stands for naltrexone. Naltrexone is the drug that's been developed to counteract opiates. So if you take LDN with an opioid of any sort, it will not be effective. That's one of the few reasons or one of the few issues that have to be avoided. You cannot use LDN and an opioid and expect a lot of success.
Barry, I'll just jump in on that real quick.
Sure.
We have had some success with using ultra low dose and very low dose naltrexone. they can, if they're taking their opioid in the morning, because you're right, it is short acting, they can try to take some LDN at bedtime. By the time they wake up, it is worn off and they can take their pain meds during the day. And sometimes you can work with them trying to get them off their, it might be an adjunct to helping them with their, tolerate their pain meds and modulate them.
If the LDN is tolerated at bedtime, that's absolutely true. And in that case, you have to be flexible, and it would have to be a shorter acting opioid. If you're giving
Correct.
a long acting opioid, it's not
Right.
going to be as effective.
It has to be a 4 to 6 hour opioid. It can't be a 24-hour
Right.
opioid. Correct.
Right.
Okay. And we have another question. I have spinal stenosis. What would be in the other approach? What would be in another approach other than epidural and target injections? Would you suggest acupuncture?
Okay. So acupuncture, first of all, has almost no contraindications other than if you have a bleeding disorder or if you've had some kind of allergic reaction. Spinal stenosis is very interesting. There's severity and degrees of spinal stenosis, and it also depends where in the spine. Epidurals offer only temporary relief. What's happening is this. This is the visual I like to give patients. Think about a tunnel, say the Lincoln Tunnel, and let's say there's a big 18-wheeler. The Lincoln Tunnel is your canal of the spine, and the 18-wheeler is the nerve, the spinal cord traveling. Let's say suddenly a boulder for some reason finds its way in there, and that is going to cause problems. So this is why epidurals don't work for long periods of time, because they don't really change the compression on the spine. But of course, spinal stenosis has degrees. What if that boulder is really a pebble? Or what if it's a very small rock? Well, it's not going to cause a lot of trouble. So it has to do with the symptom complex. For example, can you walk up and down stairs? Are you feeling tingling in your legs? Are you feeling weakness? Are your reflexes affected? What is the MRI, which is a test that's typically important to determine the degree of stenosis, show? So is acupuncture something that I use in my practice? Absolutely. Can it work on all forms? No, it can't.
Okay. We have another question about LDN, and I think Phil might be able to jump in on this too. Does insurance cover LDN? If not, how much does it usually cost?
That's up to your own insurance company. And what we recommend doing is calling your insurance company, asking if they cover compounded medications. And then if they do that, then there's a good chance you will be covered. What we charge for a month's supply of LDN is only $49.50. So it really depends on what your copay is. If you have a $50 copay, the medication is less than your copay. That's been our experience.
Mm-hmm. Also, Dr. Erner, could you discuss a little bit opioids as an option?
Okay. Opioids are a very complex issue. So I'd like a little bit more specificity to that question, because you have short acting, you have long acting, you have chronic pain that can be related to cancer. You can have, I need a little bit more information for me to give a really good answer.
Barry, I tried to draw you into it because I wanted to get your approach on opioids and how it incorporates into your practice today, even with all the, information out there, because it's still, I'm sure, a piece of your practice.
Of course. Okay, so here's the issue. Two things. First of all, any patient that I'm going to use opioids for will have to sign a pain contract. And what that will mean is that they have to be willing to be subject to a random test of urine, and B, they can't doctor shop. What that means is I have to be the sole provider of the opioids. That being said, I have used opioids in the practice for over 30 years safely, and patients are able to take them and maintain their activities of daily living and successfully navigate their use. I instruct them on the different types, which ones will be more effective, and they're almost always used in conjunction with other modalities. In and of itself, it is not enough. An opioid by itself is not enough, but it can be very, very useful with other medications and other modalities.
All right, thank
So in
you.
other words, you don't want to throw the baby out with the bathwater. You know,
Exactly.
it's still a piece, still a piece of your practice. It's still useful. And when used properly, you're still going to get results.
What's happened, and again, I don't want to get into politics of medicine, but what happened is you had really a little bit of a witch hunt against the company that produced OxyContin, and what the psychosocial effect of overuse. In other words, like anything else, there are some practitioners that shouldn't be prescribing them. And what was happening was they were being a little bit cavalier, meaning that they weren't careful in their prescribing, and it created a social issue that became epic magnitude of disaster. And so what happened is at that point, the government had to step in and it vilified everything to do with opioids. And that really wasn't fair because they've been around for 150 years and have successfully treated pain. So again, you have to have a practitioner who has a better handle and experience in their use and can explain it to the patient and to recognize it's part of a greater program, not just the opioid.
Thank you for explaining that, Dr. Erner. All right. If anybody else has any questions, feel free to raise your hand and use the mic or write in the chat or the Q&A. All right. Well, Dr. Erner, if we don't have any other questions, we want to thank you for coming tonight. It was very informative.
It was my pleasure.
And Barry, do you want to give them your contact information? And we're going to be posting this up on our YouTube channel in the next few days. So if people want to review it and be able to ask you questions.
Unfortunately, I did not put a slide with my contact information. There you go.
Well, next time.
So there's a reason to call Phil. Anyway,
Yep,
thank you so much for allowing me the chance to converse about something that's really very, very important and certainly needs better quality of care than is being delivered right now.
But Barry, if you want to give them your phone number or your website or email, this way they can, if they want to get a hold of you, they can get a hold of you.
Sure. I'll give you my office number because that's the best way to get hold of me. Because I actually have a live person who answers the phone.
Anne-Marie's great.
We actually
answer our phones.
I'm that old fashioned that I actually have somebody who actually is alive and will answer the phone. So the number is 914-238-1205. And I just wanted to I just realized there's one more thing I wanted to mention, which I didn't cover, and it's really wrong. There's something called ketamine, which is really important as part of the treatment of chronic pain. And I really think that it deserves attention. And so I'm just going to talk for one more minute, if that's all right.
Yeah, of course.
Go for it.
Okay, thank you. So ketamine is a short-acting anesthetic that has now found itself to be one of the most useful adjunct medications in the treatment of chronic pain. It works on many different levels. In fact, it's one of the medicines that's actually being used now for PTSD, which is post-traumatic stress disorder. And that disorder is something that's often accompanied with chronic pain. It's basically an anesthetic. And you think of a short-term anesthetic, well, how is that going to help? Well, what they have found is that it has effects beyond the simple anesthetic. It works on parts of the brain that modify our perception of not only pain, but improve mood, improve our actual pain perception. There's something that's known as phantom limb pain. What is that? That is where, unfortunately, somebody suffers an injury and may have an amputation. We know that that there's no arm there, for example. Let's say it's the right arm. They will say, I'm feeling the arm hurt. There's no arm there. Well, the brain has created a pathway where it still thinks the arm is there. And ketamine can create a state of amnesia of sorts, amnesia meaning forgetfulness, that can actually recircuit the brain so that you don't feel that chronic pain. So I just want to mention that's another modality that I really have been using in my practice. And Phil has been really helpful because he can actually titrate that dosage, and it can be administered intranasally, which makes it incredibly handy because you can keep it with you. And if the dosage is at different parts of the day, you just basically take a spray up the nose. And it sounds a little funny, like up your nose with a, whatever, but it actually is incredibly useful and incredibly helpful. And I have been using it in the practice now for a few years, and Phil does a remarkable job of helping me in that. So I just wanted to bring that up. I think that was really important.
Wow, thank you for that, Dr. Erner. It's a very good takeaway. We also have a patient that's asking if you have an email address they could email you.
I do. So my email address is DRERNER, Dr. Erner, 121@gmail.com. So it's Dr. Erner, my last name, ERNER, 121@gmail.com.
Perfect. I just put that in the chat as well.
Thank you.
Yeah, absolutely. I think
And now
Phil
I
has
can-
to run, but
No, I'm still here. I haven't ran yet.
Okay.
I'm close to it. But I
Okay.
want to thank everybody for joining us tonight, and especially Dr. Erner, and giving us this knowledge and explaining things that I picked up along the way. And it's always a good thing when you learn something new.
My
And
pleasure.
Dr. Thanks for joining us.
Thank
and
you so
thank
much.
you.
Again, have a good night, everyone. Be well.
thank you,
Thank you.
Dr. Erner. Good night.
Good night.
Yeah.